Hello friends, welcome to Health, Music and Fitness channel.
In this video we'll discuss about conduction abnormalities, and for that we have to know what the normal conduction is like. As in the previous videos we have discussed, the impulse starts from the SA node and then it spreads to the right atrium and the left atrium, and then the impulse reaches the AV node, and in the AV node there is a little delay, and then the impulse goes to bundle of phase from where two branches start, a right bundle branch and the left bundle branch. The left bundle branch further divides into left anterior fascicle, which lies superolaterally, and left posterior fascicle, which lies infero-medially. And there is a right bundle branch which supplies the right ventricle, and the left anterior fascicle and the left posterior fascicle, they supply the left ventricle. So this is the normal conducting system of the heart, and this is the fastest conducting system. Whenever the impulse starts from some other area in the heart, it spreads slowly in the myocardium. So that is why you get a broad QRS whenever the ventricles fire and they produce a ventricular ectopic. So in a VPC, ventricular premature complex or ventricular ectopic, the QRS is broad. And whenever the impulse travels through this normal conducting system, the QRS is of normal duration, that is less than 3 small squares, 0.12 seconds. In WPW syndrome, the QRS is sometimes broad when the impulse travels through an aberrant pathway. So at this level, in short, broad QRS can be because of left bundle branch block, right bundle branch block, a ventricular premature complex VPC, or an impulse from the supraventricular region traveling through an aberrant pathway like in WPW syndrome. So these are the 3 or 4 major causes of broad QRS. At this level you should know this much. There are other conditions in which QRS can be broad, like in ventricular tachycardias and in AIVR, augmented idioventricular rhythm, and torsades de pointes. And we'll discuss about these in later videos. We'll not talk about them right here, but you can remember these are also causes of broad QRS. The short form for left bundle branch block is LBBB, and for right bundle branch block, RBBB, right bundle branch block. And left anterior fascicular block, LAHB, left posterior fascicle block, LPFB. We'll be talking about these blocks using their short forms, and it is very easy and simple to remember that left bundle branch block causes left axis deviation, right bundle branch causes right axis deviation. Right now we'll focus only on these two blocks, LAHB and LPFB. We'll discuss later. Now for left bundle branch block and right bundle branch block, the impulse is spreading from one chamber to the other. Let us say for left bundle branch block, we'll block the left bundle branch out here, and now the left ventricle has to be stimulated because life has to be sustained. God has made our bodies in such a way that the heart keeps on pumping till the end, come what may. If the SA stops firing, it is a tendency of the heart to fire take over. So left bundle branch block, let us block this left bundle branch out here. If then the right bundle branch, AV nodal rhythm starts the impulse, even that doesn't happen, towards the ventricular ectopic, pacemakers will take over. So it causes through the left axis deviation. Through the right ventricles will try to fire. It spreads the impulse towards the left ventricle. So the vector is changed, and the impulse goes towards lead 1 and AVL. So what is happening for lead 1 and AVL? The impulse is going towards lead 1 and AVL, and it will be perceived as a good positive upright deflection. So what you see in left bundle branch block, lead V5, lead V6, so they are looking towards the lateral wall. And what do you see? Tall are in V5, V6 and deep S in V1, V2, because I told you V1 and V2 electrically they are opposite to V5, V6. If something tall happens in V1, V2, deep S will be created in V5, V6. Tall are in V5, V6, deep S in V1, V2. So it is like this only, because current can travel only in one direction, current cannot travel in both the directions. So from right bundle branch the impulse goes towards the left ventricle, so it causes a shift of the axis from somewhere between 0 degree to minus 90 degree. So that in that quadrant your axis will be lying. Now what is important is the impulse is spreading from one chamber, from the right ventricle to the other chamber, that is the left ventricle. So there is a delay in the spread, and that broadens the QRS. So for the complete criteria for left bundle branch block would be tall R in V5, V6, deep S in V1, V2, broad QRS, that is more than 3 small squares. 1 small square is 0.04 seconds and 3 small squares will be 0.12 seconds. So more than 3 small squares duration, and ST depression with concavity upwards, and T wave inversion, because there is a repolarization delay also, that is why the T inverts. This is the and a left axis deviation. So this is the complete criteria for left bundle branch block. Similarly for right bundle branch block, let us block the right bundle branch out here. The right ventricle has to be stimulated because it has to pump the blood into both the lungs, and so for that the left bundle branch supplies the electrical current towards the right ventricle. So what is happening for lead AVF? Lead AVF is becoming more positive. You have to use a little bit of imagination. Lead AVF current is coming from the lateral side towards AVF, lead 3, and it is causing a shift of the axis towards plus 90 to 180 degree. So that will cause a right axis deviation. And what else will happen? It is from one chamber to the other, from left ventricle to the right ventricle. So what happens? The QRS duration is more than 3 small squares. If it is between the same chamber, then the QRS will not be broadened, like in left anterior fascicular and left posterior fascicular blocks we will discuss later on. The QRS is not widened. So you can also remember like this: R for right axis deviation, R for right bundle branch block, L for left bundle branch block, L for left axis deviation. So it's a mnemonic. Also in right bundle branch block you will see a R dash pattern in V1 and sometimes in V2 also. Tall R in V1, V2, deep S in V5, V6, broad QRS more than 3 small squares, ST depression with concavity upwards, and a inverted T with a right axis deviation. So this is the complete criteria for right bundle branch block. So it is very easy to remember the findings of these two blocks, and always when you have to comment on LBBB, left bundle branch block, look only in leads V5, V6. When you want to comment on right bundle branch block, or you want to look for right bundle branch block, look only in lead V1 and V2. Now we'll look at left anterior hemi block. Now you know left bundle branch divides into left anterior fascicle, which lies supero-laterally, and left posterior fascicle, which lies infero-medially. Now let's put a block at the left anterior fascicle. Now that part, the lateral part of the ventricle, has to be stimulated because it has to pump. So the impulse won't come from the right bundle branch, rather it will come from the left posterior fascicle, and the vector will again be directed towards lead 1, AVL, and so I had told you in the previous ECGs, if lead 1 becomes positive, AVF will become negative because current can't travel in both the directions. It causes left axis deviation. Now, what is happening for lead 3 in left anterior fascicular block? Impulse is going away from lead 3. So you will see a S wave in lead 3, deep S wave in lead 2, and the axis deviation towards the left more than minus 30 degrees. And the QRS is narrow because the conduction is occurring within the chamber, intra-chamber. It is not interchamber like in LBB and RBB. The impulse is traveling from one chamber to the other chamber, but it is not happening in left anterior hemi block. So the QRS is of normal duration, less than 3 small squares, left axis deviation, S wave in lead 2 and lead 3. So this is the criteria for left anterior hemi block. In fact, in 80 to 90% of the ECGs with left axis deviation, they will have a S wave in lead 2 and lead 3, and that is because of left anterior hemi block. And mind you, left anterior hemi block is a serious thing, and compared to the right ventricular blocks, like in COPD it is very common to see a right bundle branch block, and that is less serious, but left bundle branch block, left anterior hemi block, they are more serious. Now we look at left posterior fascicular block. You block the left posterior fascicle, it lies infero-medially. So the impulse will come from left anterior fascicle, it will go towards lead AVF. The vector is directed to lead AVF. AVF is becoming more positive and lead 1 will become negative automatically. So the axis is lying in right axis deviation quadrant. So there is a right axis deviation. Again, the conduction is occurring in intra-chamber within the same chamber. So the QRS is not broad, it is less than 3 small squares. So left posterior fascicular block, there is right axis deviation, QRS is of normal duration, less than 3 small squares, 0.12 seconds, it is less than that. And left posterior fascicular block is a diagnosis by exclusion. You should rule out other causes of right axis deviation like right bundle branch block, incomplete right bundle branch block, or pulmonary embolism, or anterior wall MI. You should rule out all these conditions, right ventricular hypertrophy, and if these are not there, then you may label as left posterior fascicular block.
If you like our videos, please subscribe to the channel, tell your friends also to subscribe and give a thumbs up, and like our videos, comment on the videos, and hit on the bell notification icon, and please visit again and again and spread the word around. Thank you.